there's a lot of stuff that we've published, which is available on the Health Foundation website. So we looked at non-attendance rates in my diabetes service, for example, using face-to-face versus a mix of face-to-face and virtual consultations. And what we showed was it really is important to do two things. One is the technology that is used has to be very user-friendly. And two, you have to make wider transformations to the outpatient pathway. So you're not just technology focused, but you're actually making the whole pathway more user-friendly. And when you do that, we showed at the start of our work in 2011, the baseline non-attendance rate was anything from 33% to 50%, depending upon the age group. But as time went by and people got more used to online contact, and the software that we were using got more user-friendly, the DNA rates dropped to about 26%. And then we started actually creating more user-initiated contact. So we would give people fixed appointments when we needed to physically examine them. But in the interim, we asked people to book an appointment depending on need at fixed time slots. And we found the DNA dropped to about 11 to 13% for the same group of people. We also showed an improvement in glycemic control in the diabetes clinic, which reflected probably greater self-management skills and greater engagement. And that's been something that has been replicated in other services. So I think the key to it is making sure that the technology is not something that requires a postgraduate qualification to use something that people can use very easily and readily, and not to do it in silo, but to make sure that the whole pathway, blood testing, booking appointments, feedback of results, clinician-patient interaction, all of that is more user-friendly and co-designed.
That's really helpful, Shanti, and great that you've got that that data. Was that baseline, that DNA, was that the DNA for face to face, or for the big? Yeah, it was. Okay.
So we took people who had done at least 2 consecutive follow-ups, because we found a lot of people tried it once and didn't try it, or didn't like it after using it for the first time. So we wanted to make sure they were persistently using it. Also, it required people to get the hang of it, really. And so we took the baseline face-to-face, and then we took a mixed match of face-to-face and virtual for the same group of patients. And we have actually published a fair bit on quantitative and qualitative outcomes from all our projects so far. The references are on our Scaling Up site on the Health Foundation.